Ciao mondo, hello world, hola mundo, hello monde, ni hao, konnichiwa. All friends of the world are united for the fight of acute kidney injury in the pediatric population, but no one more than people at Cincinnati Children's Hospital and also the new chief of pediatric intensive care in Florence, Italy, Zaccaria Ricci. So first we welcome Zaccaria as a freshly nominated chief of intensive care at the pediatric department at the Mayo Hospital. And of course, then I'm more than happy to welcome Jolene Morgan, who is a nurse practitioner and taking care of acute care treatments in the pediatric department, supervised, of course, by our friend Stu Goldstein, who is the master of ceremony of pediatric CRRT in the world, probably. I'm very happy to have this Cappuccino today, unfortunately not in person, but we have to celebrate something. As you know, in 2013, we did the first human treatment with the Carpediem machine, cardiorenal pediatric dialysis emergency machine in Vicenza, Italy. And since then, we have treated now more than 60 babies around Europe, reducing mortality in a very significant way. But now Carpediem has crossed the ocean and has landed into United States, where FDA has recently approved this fantastic equipment for our babies and neonates. So first of all, I would like to ask Zaccaria to quickly comment on the development of Carpediem at the time he was a fellow in our division in Vicenza.
Oh, thank you, Claudio. That was a great honor and a pleasure because, you know, when you see the baby machine growing within your hands, and then you have the possibility to actually use it in real patients and in little children. It's such a wonderful pleasure and grateful occasion. So I was honored because with you, I have the possibility to use the white machine that nobody have ever utilized. So not only the pink one, but also the white one.
So the real prototype, actually.
It's our little baby.
And what was the first impression you got from this machine, Zaccaria?
What really impressed me at the very beginning was our tests with the small catheters and the possibility of utilizing it, even if at that time in vitro, with a 4 French catheter that was actually working. So when then you had the real possibility to apply the machine to that catheter, that was really quite such an achievement. I mean, because we could have the possibility of actually changing the way we are applying to the smallest and below 10 kilograms.
So, Stu, how was the path to get Carpediem approved in United States?
Hi, Claudio, and hi, Zaccaria. Yes, so the path was we were able to use historical data from the Italian registry of nearly 40 patients who had been treated with the Carpediem. And we compared the outcomes of those children with a size-matched cohort from the prospective PT experience from the prior decade, which is a registry, as you know, that I helped run. And what we did was, when we controlled for severity of illness, when we controlled for fluid, in terms of needing mechanical ventilation or invasive or stressors, the survival to CRT discontinuation was significantly better in the Carpediem group. And while the significant, it was much better in the Carpediem group. The FDA really made sure, because they're very interested in safety, obviously, that all of the safety parameters were as advertised and as we had discussed with them, because they were not requiring a prospective study in the United States to show efficacy. And I can't remember a situation where registry data from another country has been utilized as the primary source for FDA approval. This really shows how detailed and complete the Italian registry data were to allow this to be approved for children in the United States.
So, Jolene, besides the success of treating the first babies in the United States with Carpediem, it seems that you were the first in the world to carry out a special treatment with Carpediem, connecting it to an ECMO machine and circuit. So how was the experience to explore this completely new pathway? I must say that I sympathize very much, because we did the first CAVH, we did the first CVVH with Carpediem, so I know how it is. Our pediatricians used to say, where are the guidelines? And I used to say, we are going to write the guidelines. So how was your experience?
It went very well. So we actually used one of our ECMO circuits, which at the time it was the Spectrum CP22, which is very similar to the HL20. And we trialed the connections with the Carpediem and the ECMO circuit with multiple different pressures, and tried to figure out where to connect in so that we wouldn't have continuous alarms. We first used crystalloid, and then we did a second trial with packed red blood cells with expired blood, and had the same results from a pressure standpoint from where we were connecting in and everything. And then the best part of it all is that we were able to take our knowledge from the trial and translate that into practice and use it on, a patient who needed, renal replacement therapy while on ECMO. And we had the same experience that we had in our trial, and we actually ran for 4 days without any alarms. So it was really a phenomenal, experience to be able to translate that.
So people are especially interested to know, where did you connect the two lines, arterial and venous line, and if you had to make a special constriction or any type of strategy to make the circuit working.
Right. So we connected. We first connected post ECMO pump, pre-oxygenator, so in what they call like the safe zone, or the positive portion of the ECMO circuit. What you have to be cognizant with that section, especially with your CRT return pressure, because that return is typically connected right before the ECMO oxygenator. So if your ECMO pre-membrane pressures are 200 or greater, you're likely going to have high return pressures, which will result in the high pre-filter pressures on Carpediem. So if your ECMO membrane pressures are elevated, you may want to consider moving your CRT return line to the negative aspect of the ECMO circuit, which could be like the venous sampling port. And then once you do that, your return pressure on CRT will actually become negative. And you have to apply a little bit of compression, using a C-clamp or, something to create that positive pressure or get that resistance so that your CRT return pressure is positive.
When you connected to the positive pressure part of the circuit, the arterial line, did you have to put a constrictor in order to get a negative aspiration pressure?
Yes, we did. And so yes, if your CRT access is connected in that positive portion, then yes, you do have to apply compression to obtain that negative pressure. We did move it to the venous aspect of the circuit, and it had enough negative pressure to where you did not have to apply any compression.
Okay. Stu, how important at this point is your simulation center in Cincinnati? I think this is a fantastic area for exploring different connections and possibilities and teach people how to do things, right?
Yes, thanks, Claudio. We run both an internal simulation for our own faculty, nurses, and fellows, and then we've hosted a CRT university where folks have come from around the world to help them develop a program, improve best practice, and rethink things like how to do anticoagulation, how to do some things that are quite novel in pediatrics. And we've had a good collaboration with our ECMO team to do simulation because we do a lot of CRT on ECMO. And the first question or second question that everybody asks me about Carpediem is, have you done it on ECMO? And until 2 weeks ago, I'd said, we've only done it in simulation, and we think we know what we're going to do, but we marched down the exact pathway that Jolene and the ECMO team did in simulation to prove and validate what we had seen there in the patient. So simulation is absolutely critical to be able to go in to take care of a patient with some confidence when you're doing a new therapy.
Zaccaria, did you have any experience when you were in Rome connecting Carpediem with the ECMO circuit?
Not really, because we were afraid of pressure alarms, and we knew that the machine actually couldn't be connected to ECMO. I have to say that we were using the very first release of the machine, and probably at that time was not so prudent to do something like that. And furthermore, we didn't have any simulation center, so we couldn't try it before. And I think that that's a very smart idea, and that was really probably the final goal for do that.
So guys, I would love to stay to talk to you two forever, but our cappuccinos are much shorter. Normally, this was a special cappuccino. Anyway, Stu and Jolene and Zach, I think it would be very nice if we have the possibility in the near future, maybe to write a narrative review on the pathways to go to a connection of Carpediem into the ECMO. Just for educational purposes, but also to teach young fellows and people that new pathways can be explored with prudence, with competence, but this is the way we move science ahead. So with this, thank you very much. First of all, Jolene, it's been a great pleasure to meet you, and I'm looking forward to come back to Cincinnati, not only for the Children's Hospital, but also for the wonderful hospitality that you always offer to us. Zaccaria, hopefully we will meet soon in person. I don't know when, but and so. You know, Zaccaria and I just completed the short course for nurses in Italy, and we had 850 people registered at the meeting. So that was a very, very important success. With this, thank you all for following today Cappuccino, and hopefully we will have many other opportunities when more people are going to be treated in Cincinnati and throughout the United States. Thank you all, and have a wonderful day.
Excellent.
Thank you so much.
Thank you, Claudio.